So the next alteration in cardiovascular pathophysiology would be hypotension. We see hypotension quite often in the elderly, and a lot of their complaints, they come in with syncope or near syncope or dizziness or lightheadedness. So the term orthostatic or postural hypertension means a decrease in the systolic and or diastolic arterial blood pressure on standing. And the American Autonomic Society and the American Academy of Neurology define orthostatic hypertension as a systolic blood pressure decrease of at least 20 millimeters of mercury or a diastolic blood pressure decrease of at least 10 millimeters of mercury within 3 minutes of standing up. And it can be characterized as arterial, venular, or mixed issue. When a normal individual stands up, the resultant gravitational changes on the circulation are compensated for by several mechanisms, which include the reflex arteriolar and venous constriction, increased heart rate, mechanical factors such as the closure of the valves in the venous system, pumping of the leg muscles, and decrease in the intrathoracic pressure. The normally increased sympathetic activity during upright posture is mediated through stretch receptors, baroreceptors in our carotid sinus and in the aortic arch. The reflex response to the shifts in volume is caused by postural changes, leads to a prompt increase in heart rate and constriction of the systemic arterioles, which maintains a stable blood pressure. These compensatory mechanisms are not effective in maintaining a stable blood pressure in individuals with orthostatic hypertension. So again, know what happens when we normally stand up and when it's not happening. When we stand up, we can better treat it. So it can be acute, it can be temporary, it can be chronic. Acute orthostatic hypertension is its temporary type. It's caused by the normal regulatory mechanisms are sluggish. It may result in an anatomic variation, altered blood chemistry, drug reaction. Could be the medicine that we gave them for hypertension, now it's causing them to be hypotensive. Or it could be from an antidepressant that we just prescribed for them 4 months ago because they were depressed or whatever. Prolonged immobility caused by illness, starvation, physical exhaustion, any condition that produces volume depletion, electrolyte imbalances, venous pooling. And again, older adults are susceptible to this acute orthostatic hypertension, in which the postural reflexes are slowed as part of the aging process. So normally we have that, those postural reflexes, stretch receptors they're not as fast. Our reflexes slow down as we age. Then you can have a chronic orthostatic hypertension too, which is secondary to a specific disease, or it's idiopathic or primary is what we call it. And you can read about those causes as well. So more diseases of the arteries, and we couldn't talk about coronary artery disease before we talk about arterial sclerosis or atherosclerosis. So arterial sclerosis is a chronic disease of the arterial system. It is caused by, or it's related to abnormal thickening and hardening of the vessel walls. The smooth muscle cells and the collagen fibers migrate to the tunica intima. And then we have atherosclerosis, which is a form of arterial sclerosis, which is thickening and hardening of the vessel caused by an accumulation of lipid-laden or fat-laden macrophages within the arterial wall. This leads to the formation of what we call plaque. Atherosclerosis is not a single disease, but rather a pathologic process. that can affect vascular systems throughout the whole body, resulting in ischemic syndromes. And it is the leading contributor to coronary artery disease and cerebrovascular disease. You can, atherosclerosis of the coronary arteries is described in page 1116, and then atherosclerosis of the cerebral arteries is discussed in chapter 17, just in case you want to read that or brush up on that. So there's still some considerable controversy as to the pathophysiology of atherosclerosis, but the widely accepted theories of the mechanism of this is based on the finding that atherosclerosis is an inflammatory disease. Pathologically, the lesions progress from endothelial injury and dysfunction of the fatty streak to the fibrotic plaque to a complicated lesion. Atherosclerosis, it begins with injury to the endothelial cell that lines the artery wall. Possible causes we've talked about, but we'll recap here: smoking, hypertension, diabetes, increased levels of low density lipoproteins, LDL, decreased levels of high density lipoproteins, HDL, and then autoimmunity. So once you have this endothelial injury or dysfunction, which leads to inflammation of that endothelium, the following will occur, and we'll just kind of do like a list effect here. You get an injured endothelial cell, which becomes inflamed, can't make any more normal amounts of antithrombotic and vasodilating cytokines. Number 2, you get numerous inflammatory cytokines that are released, including tumor necrosis factor alpha, TNF-alpha-A, interferon-gamma, IFN-Y, and interleukin-1, IL-1, which is toxic oxygen radicals and heat shock proteins. And the next that comes along, you got macrophages that adhere to the endothelium by the way of adhesion models, such as vascular cell adhesion model, molecule 1, VCAM1. And the macrophages then release enzymes and toxic oxygen radicals that create oxidative stress, oxidative LDL, and then further injure that vessel wall. And then you got growth factors that are released, including angiotensin II, fibroblast growth factor, platelet-derived growth factor, and they stimulate smooth muscle cell proliferation in that affected vessel. So you've got lots and lots of mediators and inflammation and things that are wreaking havoc to the inside of that vessel. And one of the most important steps in that whole process we just talked about is the oxidation of the low density lipoprotein, because that inflammation doesn't come without oxidative stress. It activates the macrophages, and it just wreaks havoc on those vessels. Anything that's in there, it's going to disrupt, or it's going to just attack it till it does disrupt. And things that will increase your LDL oxidation is diabetes, smoking, hypertension. So I'm sure you see the correlation with many of these things. Oxidized LDL is toxic to endothelial cells, so very important. The smooth muscle, this causes the smooth muscle to proliferate, which activates further immune and inflammatory responses, as we said. So this is just sort of a recap of what we had just talked about with what happens with endothelial injury. There is atherosclerosis. Again, LDL enters the intima through intact endothelium, number 1. Number 2, you got intimal LDL, which is oxidized into pro-inflammatory lipids. Ooh, it sounds cool, but it really isn't. Oxidized, then you number 3 there, you've got this oxidized LDL causes an adhesion and then an entry of a monocyte, a T lymphocyte across the endothelium. And then number 4, back down here, you've got a monocyte which differentiates into a macrophage and consumes large amounts of of LDL transforming into foam cells, and then the foam cells release growth factors, cytokines that encourage atherosclerosis. So they suck them up, and you think, oh, they're going to take them away, then nope, all that stuff is just, all of those mediators are in one spot, and now they're just causing a ton of havoc wherever they flow by or end up. Again, another picture of what we had talked about, and you can, I always like diagrams to kind of, and I, write down in my own head the process, so when I need to go back and remember it as to what's going on with my patient, then I sort of have that mental picture. So coronary artery disease, you're going to see lots and lots of patients with coronary artery disease. Coronary artery disease, myocardial ischemia, and myocardial infarction form a pathophysiologic continuum, which impairs the pumping ability of the heart by depriving the heart muscle of blood-borne oxygen and nutrients. The earliest lesions of the continuum are those of coronary artery disease, which is CAD. Virtually any vascular disorder that narrows or occludes the coronary arteries. And then by far the most common cause of coronary artery obstruction is atherosclerosis, which we just talked about. And coronary artery disease can diminish the myocardial blood supply until deprivation impairs myocardial metabolism enough to cause ischemia, a local state that in which cells are temporarily deprived of blood supply. They remain alive but cannot function normally. They're sort of stunned. Persistent ischemia or incomplete occlusion of a coronary artery causes acute coronary syndrome, including infarction or irreversible myocardial damage. Infarction constitutes an often fatal event that we call a heart attack. So risk factors, you can read there, many of what we just already talked about. You get this defect in the production of precursor endothelial cells, and then these cells are not available to help repair the injured endothelium for whatever reason. If you've got all of these things going on, dyslipidemia, hypertension, cigarette smoking, diabetes, obesity, it's just crazy. And you have some non-traditional risk factors, which include these autoimmune diseases, these C-reactive protein diseases, or fibrin impairment. You got familial hyperhomocysteemia, infection. So there's a strong correlation between lipids or lipoproteins and coronary artery disease, and we define this as an abnormal concentration of serum lipoproteins, which is defined by the third report of the National Cholesterol Education Program. And you can see that table on table 30-5 in the book. It can be primary or familial dyslipidemias. And so an increased serum concentration of LDL is a strong indicator for coronary risk. This is responsible for the delivery of cholesterol to the tissues. LDLs are normally controlled by hepatic receptors or LDL that bind to LDL, or receptors for LDL that bind LDL and limit liver synthesis of the lipoprotein. High intakes of cholesterol and fats, often in combination with genetic predisposition, causes accumulations of LDL in the serum and results in high levels of LDL in the bloodstream. And it's good probably to define that LDL actually describes several types of LDL molecules in general. So you have the small dense LDL particles that are most atherogenic. LDL also plays a role in LDL oxidation, migration, which migrates in, never mind. And these LDL particles play a role in endothelial injury, inflammation, and immune responses that are also identified as being important in atherogenesis or atherosclerosis. lipids are processed in two ways, which is sort of good to know, some good information to know because of how the medications will work. Exogenous pathways, which absorb fats from the digestive tract into the circulation, and endogenous, which transports fats synthesized in the liver between the liver and the peripheral tissues. So LDL's low-density lipoprotein is often referred to as the bad cholesterol, while HDL or high-density lipoprotein is a good cholesterol. And this is because the LDL largely transports cholesterol to the periphery, where it may be incorporated into atherosclerotic lesions. And HDL mostly transports cholesterol back to the liver from the periphery. So an important note here is if you see, especially on the elbows or around the Achilles tendon, the Achilles areas, knees, you see fat deposits, little fatty deposits. You might want to check likely want to check their cholesterol. Their LDL is probably high, and it's likely going to be a familial type of cholesterol because of that LDL that transports that to the periphery. And so the reason for trying to target the HDL is to increase that mechanism that gets that transports the cholesterol back to the liver from the periphery, so you want to get that out of there. So that's the goal. And then here's a diagram that shows the travel of exogenous sources of lipids, your dietary intake, and how how all that play, what the actual sequence is of how that happens. How does this lipid form? And this is a course in of itself, really. So if you have some questions, more in depth about that, we can certainly do that at a different, email or calling, or I can even give you some good information about that. Here's a summary of drugs used to treat hyperlipidemia. It's a good thing just to sort of print out and have on hand if you're in practice and you just kind of want to pull out your iPod or your phone and look at your Medscape or prescriber's letters, whatever you're using. Hippocrates. This is good as to what's your LD or what's your cholesterol panel say, what meds are going to target what you want to work or what you want to change, and then what are some side effects. So we'll move on to myocardial ischemia. Normally, the coronary arteries supply blood flow sufficient enough to meet the demands of the myocardium as it labors under various workloads. Oxygen extraction from the vessels occurs with maximum efficiency. The efficient exchange does not meet myocardial oxygen needs. If the exchange does not meet myocardial oxygen needs, the coronaries are able to dilate to increase the blood flow of oxygenated blood to the myocardium. And in a variety of pathological mechanisms, a variety of pathological mechanisms can interfere with blood flow through the coronary arteries, which gives rise to the actual ischemia itself, which is, again, a narrowing of the artery, which impairs blood flow by more than 50%, which hampers cellular metabolism under conditions that increase myocardial demand. So if there is not enough blood supply to meet the demand, you're going to get imbalances. And then common causes of increased myocardial demand are tachycardia, exercise, hypertension or hypertrophy, and valvular disease. The most common cause of decreased coronary blood flow and a resultant myocardial ischemia is the formation of atherosclerotic plaque. So again, important to understand the pathogenesis of how that forms. And then as the plaques circulate around and they sort of get bigger or break off and end up in a smaller vessel, then that's when you get a occlusion of that vessel and you see symptoms of myocardial ischemia, because they're not getting oxygen distally. You can get symptoms of stable angina, Prince-Menno angina, silent ischemia, or angina pectoris. Stable angina is angina in the chest caused by myocardial ischemia. Discomfort is usually transient, lasts 35 minutes. If the blood flow is restored, no permanent change or damage results. Angina pectoris is typically experienced as subternal chest discomfort, ranging from a sensation of heaviness or pressure to a moderately severe pain. And this discomfort is generally mistaken for indigestion. The pain is caused by the buildup of lactic acid or an abnormal stretching of the ischemic myocardium that irritates the myocardial nerve fibers. The afferent sympathetic fibers enter the spinal cord from level C3 to T4, accounting for the variety of locations and radiation patterns of angina pain. Stable angina, caused by gradual luminal narrowing, hardening of the arteries, and the affected vessels cannot dilate in response to increased myocardial demand associated with physical exertion or emotional stress. Pains generally relieved by nitrates. Lack of pain or lack of relief indicates that they may be having an infarction. Prince-Menno angina is also called variant angina and attributes to a transient ischemia of the myocardium that occurs unpredictably and almost exclusively at rest. So that's a rest type of pain. More caused by a vasospasm of one or more of the major coronary arteries with or without associated atherosclerosis. Pain usually occurs more at night during REM sleep, and you can often see cyclic patterns of occurrence. They may come in with typical chest pain. You may see some non-specific EKG changes, and they're having this pain, and then it kind of comes and goes. You take them to the coronary vascular lab, and a lot of times what happens is their vessel sort of goes under the muscle. It's sort of an intermyocardial bridging, and so when it's under stress and your squeezability is more for trying to compensate for whatever's going on, then that's when they start to have symptoms. And again, silent ischemia is not always caused by myocardial ischemia. I'll let you read about silent ischemia. It's really about the blood flow not being able to keep up with the demands. Myocardial ischemia with mental stress. As the acute stress affecting triggers, you get an activating via the central and autonomic nervous systems. Stress can produce a cascade of physiological responses that may lead to myocardial ischemia, potentially fatal dysrhythmias, plaque ruptures, coronary thromboses, and you'll see that on EKG changes. You'll take them. So don't forget that patients that are under quite a deal of mental stress can have symptoms as well. Here it is again. You get this central and autonomic nervous system activity, catecholamines, heart rate, blood pressure changes, volume changes, coronary restriction, platelet activity. You've got these other things going on, atherosclerosis, you've had an MI in the past, you have poor circulation, you've got poor LV function, meaning left ventricular function, your ejection fraction is reduced. You can get this, sometimes you can get electrical instability, your demands aren't being met, supply isn't there. You can get a dysrhythmia, ischemia, plaque ruptures, you get a coronary thrombosis, you can either die or you get a heart attack. You just take your pick. So it's sort of a blurry image, but you can see there that what's going on there. So you've got ST elevation in leads 1, and you've got it Looks like a little bit here in ABL, but definitely V1, V2, V3, V4, V5, V6 with reciprocal ST depression and leads to 3 AEF. I mean, that person needs some help. Our primary aim of our primary goal is to get coronary blood flow restored, increase that oxygen level, decrease you want to have a balance between supply and demand. And we do that by percutaneous coronary intervention most times, or TPA if you are in a rural setting. In acute coronary syndrome, the atherosclerotic process can lead to a stable plaque formation and stable angina, or can result in unstable plaques that are prone to rupture and thrombus. The thrombus formation on a ruptured plaque that disperses in less than 20 minutes leads to transient ischemia and unstable angina. If the vessel obstruction is sustained, myocardial infarction with inflammation and necrosis to the myocardium results. You can get myocardial infarction associated with other structural and functional changes, including myocyte stunning and hibernation and myocardial remodeling. Unstable angina is a fairly small fissuring or superficial erosion of the plaque that leads to a transient episodic thrombotic vessel occlusion and vasoconstriction at the site of the plaque. The thrombus is labile and occludes the vessel for no more than 10 to 20 seconds with the return of perfusion before significant myocardial necrosis occurs. So here you have a diagram sort of outlining the events of a myocardial infarction. You've got this atherosclerotic plaque partially obstructs coronary blood flow. You can either be stable or unstable. Can either have ulceration or rupture or thrombus. If it's stable, then you have a stable angina. If it's not stable, you have an acute coronary syndrome. You either have sustained ischemia or it's transient, meaning that it goes away fairly quickly. And it can progress into an unstable angina, and it can stun these myocytes, hibernate the myocytes, or cause myocardial remodeling through a sustained ischemia pathway, mainly because you're releasing all these inflammatory and necrotic type of mediators, as we had talked about earlier. Myocardial infarction is where we have a sudden and extended obstruction of the myocardial blood flow, like we said, for whatever reason. The plaque progression is disrupted, and you get a subsequent clot formation, and the same for myocardial infarction as it is for unstable angina. But in the case of this myocardial infarction, however, the thrombus is less labile and occludes the vessel for a prolonged period, which can lead to myocyte necrosis and even death. If the thrombus breaks up before complete distal tissue necrosis has occurred, the infarction will involve only the myocardium directly beneath the endocardium, or subendocardial MI. And this usually presents with ST depression and T-wave inversion without Q waves. So we call that a non-STEMI. If the thrombus lodges permanently in the vessel, the infarction will stem through the myocardium and all the way from the endocardium to the epicardium, which we call a transmural MI, which results in a severe cardiac dysfunction. We clinically need to report or identify these people rather quickly because they're at higher risk for serious complications and should receive definitive intervention without delay. And they generally have that, marked elevations, their ST segments on EKG. So what we saw prior was an ST segment elevation at MI, or a STEMI, STEMI. And again, you get the cellular injury, cellular death, structural and functional changes. You can get that stunning, you can get the hibernating cells, and then if it lasts long enough, you get a remodeling, which is more of a thickening. So some clinical evaluation for those EKG changes we talked about, either STEMI or non-STEMI, or T-wave inversion, ST elevation or ST depression. You may see all sorts of types of rhythm if you have true transmural MI, and depending on which artery it's occluding, dysrhythmias are likely. You get a rise in your cardiac enzymes and your troponins, because these troponins are released as you get injury or death to your myocardium. You get a rise in your lactic dihydrogenase, LDH levels, and most times you see hypoglycemia 72 hours post-MI, which I did not include. That was in this slide already. So here's a picture of, see, the top one would be the circumflex, right there at the arrows, probably 99%, and then again these, it looks like it might be the LAD, left anterior descending, which is, again 99%, hang on by a thread. So disorders of the heart wall itself, you can get acute pericarditis, pericardial effusion with or without tamponade, or constrictive pericarditis. Inflammation of the pericardium, pericarditis is common following an acute myocardial infarction like we talked about, especially with ST elevation. Pericarditis is an acute inflammation of the pericardium. It's often idiopathic or caused by a virus, generally Coxsackie virus, influenza virus, hepatitis, measles, mumps, varicella. And is the most common cardiovascular complication of HIV. Constrictive pericarditis or restrictive pericarditis, or chronic pericarditis, is synonymous with tuberculosis. Years ago, tuberculosis continues to be an important cause of pericarditis, and also immunocompromised people. It's usually a gradual onset. The clinical manifestations seldom include pulsus paradoxus. Symptoms tend to be exercise-induced, dyspnea, and exertion, fatigue, or anorexia. Clinical signs may show weight loss, edema, distension of the jugular veins, or hepatic congestion. Restricted ventricular filling may cause a pericardial knock, which is an early diastolic sound. You may have some T-wave inversions, at times some atrial fibrillation. So again, you need to get an echocardiogram or a CT MRI of the chest to see what's going on. Constrictive pericarditis is where you got that fibrotic pericardium encases the heart as a rigid shell, so there's really no room for it to do its systole and diastole as effectively as it was, because it's so restricted, it's going under so much pressure. There's a picture of the pericarditis. So if you, I don't know if you can see what we mean by, by the shaggy coat of fibers covering the surface of the heart. Kind of looks like a shag carpet there. And that's the pericarditis. Got the roughened pericardial edges or membranes. You might be able to hear a friction rub, you may not. If you have them sit up and lean forward to listen to the heart, you may hear it better than if they were laying down. You want to bring that heart forward as much as you can when you're listening for those sorts of things. Some other disorders of the myocardium, which will be cardiomyopathies, can either be dilated, hypertrophic, or restrictive. Dilated is characterized by a ventricular dilation, so a big dilated ventricle, and which grossly impairs the systolic function, leading to diastolic heart failure. Hypertrophic refers to two categories of thickening of the myocardium. You get hypertrophic obstructive cardiomyopathy, and you can get, which is an asymmetrical septal hypertrophic cardiomyopathy, or subaortic stenosis, or a hypertensive or valvular hypertrophic cardiomyopathy. And these two categories are very different in their etiology, pathophysiology, and clinical presentation. So hypertrophic obstructive pathophysiology or cardiomyopathy, you have marked left ventricular hypertrophy, which often affects the septum. It's an autosomal dominant inheritance disease or myopathy. It's characterized by thickening of the septal wall, may cause outflow obstruction of the left ventricle, the left ventricular tract, I should say. And you have a collagen abnormality of the collagen deposition, or an altered contractile proteins in the myocytes, and you get this thickening, and you don't really you have impaired diastolic relaxation, impaired ventricular compliance. You may have you're going to have an extra heart sound, and then you're going to have a murmur. So if you hear any new sounds or new murmurs, patients you definitely want to get an echocardiogram to evaluate for cardiomyopathies, pericarditis, valvular diseases. And then restrictive cardiomyopathy is where you get a restrictive filling or reduced diastolic volume of either or both ventricles with normal or near normal systolic function and wall thickness. It can be idiopathic, or it can be a manifestation of other diseases. Generally those autoimmune diseases or collagen diseases. Kind of seeing a pattern here. One thing here is with the restrictive cardiomyopathy, the clinical picture overall may mimic or be confused with constrictive pericarditis. So again, echocardiogram is a good way to distinguish between those things. Here's a picture of hypertrophic cardiomyopathy, restrictive cardiomyopathy, normal physiology, and the dilated cardiomyopathy. So normal, you can see that the LV is a little bit thick, it squeezes real well, everything else is good, and then dilated, it's just that, it's dilated, the ventricle is dilated, it's thin-walled. Hypertrophic cardiomyopathies where you get this really thick ventricle, more so looks like it's more so on the right than the left. So your squeezability and your output is good. And a restrictive cardiomyopathy is just where you don't get much movement with that LV functioning at all. So valvular disorders, these are disorders of the endocardium, the innermost lining of the heart wall, all damaged, which are, start over. So disorders of the endocardium, you get valvular dysfunction, you can get regurgitation, which may be stenosis, you can get regurgitation in any of the valves, you can get a prolapse, mitral valve prolapse. So just as valvular stenosis indicates, you've got the orifice is constricted and narrowed, impedes blood flow, increasing the workload of the cardiac chamber proximal to the diseased valve. Regurgitation, it's also called insufficiency or incompetence. The leaflets or the cusps fail to shut completely, so they're permitting blood flow to continue even when the valve is supposed to be closed. So during systole or diastole, some of the blood leaks back into the chamber proximal to the incompetent valve. This increases the volume of blood the heart must pump and increases the workload of the affected chamber. Increased volume leads to chamber dilation, and increased workload leads to hypertrophy. So again, increased volume leads to chamber dilation, and increased workload leads to hypertrophy. Here you have valvular dysfunction. You've got the normal valve opening, got the cusp in the orifice. You can see that it's normally functioning. It's open, it looks good, and then when it's closed, it's closed. You're not getting any you're not getting any leakage. Stenosis valve, it's open, and you've got just a small opening there for blood flow to go in or to fill. And when it's closed, it's working against that stenosed area. It's not closing as it should. So you're going to get that backflow of blood into that left ventricle there. And then rheumatic fever. I'll let you read about rheumatic fever. read about the valvular diseases as well. These are all very in-depth. Not really much different. I mean, the pathophysiology is quite, simple, sort of close to what we've already talked about. Just more things that can happen over time, especially with the elderly population. The valvular structure and function changes. So again, echocardiogram to evaluate those. Any abnormal sounds, any changes in fluid status is a good thing. And so rheumatic fever you don't see as much anymore because of the development of antibiotics, and people are using antibiotics for strep A, beta hemolytic streptococcus infections, which does affect the mitral valve. So you always want to test, or actually I culture my throats, because most times the rapid strep doesn't show anything, and if you culture it, it eventually would grow out strep A. And so for that reason I culture all my throats. If I'm going to rapid strep them, I start them on antibiotics. If it comes back negative, we take them off of it. So you're really just preventing rheumatic fever. And this is a diffuse inflammatory disease caused by a delayed immune response to infection by the group A beta hemolytic strep. You have a febrile illness. Generally, onset of the strep is quite abrupt. And you get inflammation in the joint, skin, nervous system, and heart if it's untreated. If it's left untreated, it affects the mitral valve, and rheumatic fever causes rheumatic heart disease. So people in their 50s, 60s, you may see 70s, generally don't, some 40s, you generally don't see it in the younger people anymore. But you may. And then some complications of rheumatic fever could be a carditis, a polyarthritis, chorea, or erythema marginatum. But I'm not going to go into detail about those either. Here's a schematic of rheumatic heart fever and the rheumatic heart disease, starting with that strep pharyngitis. Group A strep sort of takes over. You get the activation of T cells by that streptococcal antigen. You get inflammation. You get all those cytokine-mediated cells of inflammation. You get vegetation on that mitral valve leaflet. Short, thickened chordae tendineae ensues, and over time you get this vegetation on that valve, which causes problems. Infective endocarditis, we'll just touch briefly, can be inflammation. It's an inflammation of the endocardium. It can be from a virus, bacteria, fungus, rickettsia, parasites. It can be on a prostatic valve, indwelling catheters after open heart surgery. It's a complex process that requires three critical elements. First is the endocardium must be prepared, usually by endothelial damage from microorganism colonization. Second, you got to have a blood-borne microorganism must adhere to the damaged endocardial surface. And third, the adherent microorganism must proliferate and promote the propagation of infective endocardial vegetation. We'll let you read more about infective endocarditis. This is what is this? This is mitral valve with bacterial endocarditis. You can see where it's kind of the vegetation there, in combination with the old rheumatic vasculitis. So you can see all the sort of the white or changes in color or echomotic sort of areas. So you got two things going on right there. This is a slide that, I don't see AIDS patients. I don't know if you do in Boise, and if you do, then you will become the expert on complications of AIDS and the cardiac complications, which I don't know if I can ever. I may have seen one patient when I was a nurse with cardiac complications, and actually they have the endocarditis from AIDS, but other than that, I do not see many patients like that. If your practice does that, again, you can become an expert on those. Heart failure is a general term used to describe several types of cardiac dysfunction that results from inadequate blood perfusion of tissues with blood-borne nutrients. And this website here is a good website to listen to a heart failure lecture from a man that is in Hawaii talking about heart failure. So when the left side of the heart fails, you have either a decreased forward flow or an increased backup of flow. If you have an increased forward or a decreased forward flow, you get symptoms of fatigue, weakness, shortness of breath. If you have symptoms of increased backflow, you get pulmonary congestion, which then turns into shortness of breath, orthopnea, and paroxysmal nocturnal dyspnea. Or if that's not limited to that, you can have an increased right heart work, which leads to right heart failure. You get a backup of this flow. You get fluid back up into the jugular venous distension, edema, and ascites. So with left heart failure, the left ventricle cannot pump as well as it should. So this causes pumping problems. This decreases the flow from the left heart to the body, and then which in turn would cause blood to back up into the pulmonary vasculature. You get your contractility is reduced, preload, or LVEDP, which is left ventricular and ventricular pressures, increases with decreased contractility, or where there is an excess of plasma volume. Increases in LVEDP can actually improve cardiac output to a certain point, but as preload continues to rise, it causes a stretching of the myocardium that eventually can lead to dysfunction of the sarcomeres and decreased contractility. Increased afterload is most commonly a result of increased peripheral vascular resistance, such as hypertension, what we talked about. As cardiac output fails, renal perfusion diminishes with activation of the RAAS system, which acts to increase peripheral vascular resistance and plasma volume, thus increasing afterload and preload further. In addition, baroreceptors in the central circulation detect decrease in perfusion, which stimulates the CNS to cause yet more vasoconstriction and cause the hypothalamus to produce antidiuretic hormone. The vicious cycle of decreasing contractility, increasing preload, increasing afterload causes progressively worsening left heart failure. So you can have a systolic heart failure, diastolic heart failure with congestive heart failure, or it can be a mix. Most times it's a mixed. And this is when you get that pulmonary congestion. And the shortness of breath or orthopnea, paroxysmal nocturnal dyspnea. Diastolic heart failure can occur singly or along with systolic heart failure. You can have either just diastolic heart failure, or you can have it occurs with the systolic heart failure as well. Isolated diastolic heart failure is defined as a pulmonary congestion despite a normal stroke volume and cardiac output. It's approximately about 50% of all cases of the left heart failure and more common in women. A major cause of diastolic dysfunction include hypertension-induced myocardial hypertrophy. So hypertension, which induces a myocardial hypertrophy or enlargement of the heart, and then myocardial ischemia with a resultant ventricular remodeling, which then this can decrease the ability of the myocyte to actively pump calcium from the systole, resulting in impaired relaxation. So it's a relaxation issue. So in short, preload fills ventricles during diastole, afterload resistance that the heart faces during systole. A little bit more in depth is preload is blood pressure at the left ventricle at the end of diastole, right before the ventricles contract. So where would this come from exactly? So originally the preload comes from the heart, from the venous system, and afterload is the systemic vascular resistance, or the resistance to flow in the arterial tree against the heart, in which the heart must work. afterload A is created by arteries A. Sort of a little helpful mnemonic. Right heart failure then is commonly caused by diffuse hypoxic pulmonary disease. So whatever causes you to be hypoxic and have in the pulmonary area is you can get this right heart failure. The left heart failure, the right ventricle is not nearly as strong as the left ventricle, and so it only squeezes into the low pressure pulmonary system, whereas the left ventricle must squeeze into the higher resistance systemic vasculature. So the right ventricular walls are thus thinner, and the walls of the more muscular left ventricle. So any processes or disease processes that increase resistance in the pulmonary vasculature, meaning pulmonary hypertension, can cause the right heart's job to be increasingly difficult for this thinner walled ventricle. So if the right heart fails, where does it go? Where does the blood go? Where does the blood in the right heart come from? So the simple answer is the body. More specifically, venous return from the body via the superior and inferior vena cava. And then what would you expect to see on a visual exam with right heart failure? So elevated jugular venous pressure, JVP. The jugular veins in the neck are straight shot to the superior vena cava, which is a straight shot to the right heart. And the JVP that serves as a sort of barometer of the right heart pressure. So where else could you get would the blood back up to? So you can get backup that can reach the liver and the abdomen and the rest of the body via the inferior vena cava. So then you will see ascites, the fluid in the abdomen, hepatic congestion, peripheral edema, fluid in the ankles and legs. This can be signs of right heart failure as well. So just to recap, right heart failure is the inability of the right ventricle to provide adequate blood flow to the pulmonary circulation at a normal central venous pressure. High output failure is on the other hand, is the inability of the heart to adequately supply the blood with blood-borne nutrients. So despite adequate blood volume and normal or elevated myocardial contraction. In a high output failure, their heart increases as its output okay, so let me say it again. In high output failure, the heart increases its output, but the body's metabolic needs are still not met. So common causes would be anemia, septicemia, hyperthyroidism, and beriberi, which you can, the figure 40 or 30-43 in your book is a good place to summarize that high output failure. It's another reason why we always in the cardiology office check CBCs, check thyroid function. If you suspect infection or some other thing, you check for it, but generally yearly thyroid studies and CBC studies, especially in heart failure patients. And here is a schematic of right heart failure. It's a lung disease. Either you got pulmonary vascular resistance or your oxygen supply is low for whatever reason. You get this right ventricular hypoxemia from the low oxygen supply. Your force of RV contraction is altered. You get this altered RV and diastolic pressure, preload, afterload, and peripheral edema, all because these things are changing. So dysrhythmias, this is actually a course in of itself. There, as you know, I'm sure already, you get disturbances of the cardiac rhythm. Most common are complications because of the things that we've already talked about. It can be ranged from occasional missed, people say missed beats or rapid beats, and that what happens is it affects the pumping ability of the heart, so they start having these beats, these altered beats or skip beats or changes in rhythm, quivering, and then they can't, the blood pressure, their cardiac output drops, or blood pressure changes, and they have symptoms and they come into you. And 9 times out of 10, you're not going to capture their rhythm that they're having when they come to see you. So if you suspect any dysrhythmia, you would obviously get an EKG if the symptoms, syncope or lightheadedness, cold sweats, those sorts of things happen at sort of maybe random times during the day. You can always send them to a cardiologist and they can get a Holter monitor, or you can call the cardiologist and see if they'll be able to send you a Holter monitor to put on your patient for review. So it can be caused by an abnormal rate of impulse generation or an abnormal impulse conduction. So this is a mechanical issue. So examples: tachycardia, a flutter, atrial fibrillation, bradycardia, premature ventricular contractions, PVCs, premature atrial contractions, PACs, and asystole, which none of us want. So I listed some YouTube videos that are well worth watching. I wish I had had these when I was learning basic rhythm dysrhythmia. And so I'm assuming that you will get dysrhythmias or basic EKG alterations in like your physical assessment portion, because you really need to be able to teach EKG interpretation hands-on by far. So if you watch these videos and over and over, and then when you are studying the dysrhythmias, watch them again and they'll make complete sense. They're really cute. You'll love them. You may have already seen them, but I just in the last year have discovered these and I love them. Any student I have, we go through them and watch them. So there's a picture of a dysrhythmia. What do you think that is? Would be my guess. I'd say VTAC. That one tells you what it is. Ventricular fibrillation. You can see it's sort of chaotic and fine and very fast. This is a slide I just included. You want to make sure you have there's a systematic way of going through and evaluating your EKG, which I'm sure you already had in basic EKG. So you want to have a P wave before each QRS complex in a consistent PR interval. So this sort of just kind of goes through and shows you what's going on and what rhythms it could be if it's prolonged or shortened. So this is a schematic of just sort of showing you accessory pathways, and this is, so it kind of goes through delta waves here. You can see in number 2 you get this nice P wave, and you got this sort of upsloping of that QRS segment beginning, and that's a delta wave. And what do you think that is associated with? You may see this, or you may not in practice, but you may be the first one to notice that there's a change in EKG in your practice, and so you need to refer them for this. So you can see on here you've got this sort of sloping of this beginning of this QRS here, right there, and sort of not really sloping, but there's a downward slope in that one. But this is indicative here of what we're trying to talk about. This is Wolff-Parkinson-White syndrome. And so you can read about that and the significance of that. So what you will see in practice is atrial fibrillation. It's very common, especially in the elderly. And this YouTube video, there's a physician that goes over atrial fibrillation quite well, so you can quit listening to my voice because it is getting very tired, and he's really good at explaining it quite well. So you have 3 classifications of atrial fibrillation: paroxysmal, persistent, and permanent. And you can read what that means right there, and what they're associated with. So you get this quivering of the atria. Sort of just quivers, you lose your atrial kick, so you're losing about, what, 20-30% of your blood cardiac output. That's why most patients will feel bad. So you need to get an echo because there's likely an underlying structural change of that atrium, or even that left atrial appendage, and you want to see what's going on. Another thing that can changes your valves and structure is snoring. If someone has prolonged snoring, they're going to get pressure changes and gradient changes within the chest, and that affects your valves. In particular, your atrium, or affects the chambers of your heart, and in particular your atrium, predisposing someone to atrial fibrillation. So overnight oximetry on especially obese snoring patients. This is just a mention of Brugada syndrome. You want to sort of pay attention to your EKG. You likely are going to find one in, I've seen one in my career for what the last, actually I saw two in the last 12 years. And so you get this ST segment elevation and a T-wave inversion in the right precordial leads, particularly V1 and V2. With a normal QRS, the widened S-wave is in the lateral leads is characteristic of the right bundle branch block, which is absent. So you want to, if you see this sort of non-specific weird EKG, you need to get them to the cardiologist, because their risk of sudden death is great with Brugada. I also want to mention too, if you're working with young children or athletes, and or you even are in contact with them, with your own kids, just remembering hypertrophic cardiomyopathy in young adults is what's causing them to have sudden death. And so, you know, there's controversy as to whether we get an EKG on all young athletes. We don't at this point, but if you have patients in your practice that come in for a sports physical, I'd talk with mom, dad about it, and say, hey, let's get an EKG so we can, you know, just make sure everything's good, structure, just make sure everything's okay. Just want to evaluate his risk, and these are the reasons why, and they generally do it. So here's something that we see, I've seen in practice many times, and they say it never happens. Well, I beg to differ, because we see it quite often in Pocatello. I don't know if it's because people are depressed or stressed or sick or what, but we see this a lot. So it's called Takotsubo cardiomyopathy. It's also called a broken heart syndrome. So the precise mechanism isn't known. All we know is that there's under extreme stress, a death, you know, domestic violence, or just any sort of major life stressor, you get this extreme activation of the sympathetic nervous system, generating a rapid response of the catecholamines in a fight or flight response. So you have this decreased myocardial uptake of this specific gene here, which is suggestive of sympathetic nerve dysfunction. Whether that is true or not, we don't really know exactly, but all we do know is that there's this extreme stress. Under extreme stress, we get this activation of the sympathetic nervous system. You release all these catecholamines. You get a stunning of the myocardium because of all of them. You get a cardiotoxicity. It mimics diffuse ST changes. You get this. You take them to the cath lab, the cardiovascular lab. When you do a left ventriculogram, you see an apical ballooning, which means this. So you get the squeezing of the left ventricle, but at the end of it, it looks like a little balloon, like if you put water in it and you squeeze it. So then that ventricle just kind of outpouches, just like a balloon would if you took it and squeezed it. But then the coronaries are normal, and you treat them just as if you would if they had an MI, because you know the myocardium is still stunned, it's still starving for oxygen, so you've got to restore all those things. And it's just not related to a blocked vessel, it's related to this excessive catecholamine release. So here are some complications of, you know, that can happen, is just similar to myocardial infarction. Most of them return to normal within several months. And those are just some ways that you can detect it, but most of the time it's because they come in with this extreme chest pain. You know, they have diffuse EKG changes, and you take them to the cath lab, and then you see this. So this is, what do you think this is? Look at the picture. Tetralogy of Fallot. So you may see this because some people will get to adulthood with this. It's characterized by a large ventricular septal defect. The aorta overrides the left and right ventricles, obstruction of the right ventricle outflow tract, and the right ventricular hypertrophy. As a result, you get this right ventricular outflow tract and a right to left shunting through the VSD. It remains the most common cyanotic malformation to reach adulthood without surgical repair. Prior to repair, they may have hypercyanotic spells or TET spells occurring during episodes of almost total occlusion of the right ventricular outflow tract and profound cyanosis. So what you do is need a chest positioning to increase systemic vascular resistance, morphine, beta blockers, fat fells, emergent complete surgical repair, or emergency aorticopulmonary shunt, which is the bladder tossing shunt. You want to do the MRI. It's the gold standard test, and their risk for sudden death and arrhythmia is the most common cause of late death following surgical repair. So you likely won't see this. I think I've seen this once, but if you work with children, you may see this. So thought it would be worth mentioning. So here are some good cardiac resources that I like. So you can listen to heart sounds and EKG tutorial. This is heart sounds and cardiac arrhythmia tutorial through the Blaufus organization. You get this library. University of Utah has a awesome free tutorial for myocardial infarction tutorial, which I highly recommend. They can explain it really well. And then the EKG Learning Center through the LDS Hospital. You can, Dr. Lindsay puts through every scenario of EKG is there. He has a basic course you can take, and so I highly recommend that as well. And then again, American College of Cardiology, so the acc.org has many resources and articles that you can, and CEUs that you can access if you remember. My two favorite books are The Rapid Interpretation of EKGs by Gail Dubin. 6th edition is bright orange, you can't miss it. It's very user-friendly, very teachable, and you'll get a kick out of his drawings. And then Braunwald's Heart Disease, the textbook of cardiovascular medicine, is standard in cardiology practice, but again, if you are in a cardiology office, it's probably not going to be all that helpful, but the other things will be greatly helpful to you for even primary practice. So I can't end a cardiac lecture without talking about some benefits of exercise, because we've got to all start exercising at least 30 minutes a day, 5 days a week. And so the potential benefits of exercise in coronary heart disease, I could have thrown this in underneath that, but we weren't really talking about treatment or benefits or anything, just sort of going over pathophysiology. But anyway, so the pathophysiology benefits of exercise, you get an anti-atherosclerotic benefit. So it improves lipids, it lowers blood pressures, it reduces adiposity, increases insulin sensitivity, it decreases inflammation. So all those things that we talked about that increase your risk for atherogenic, exercise lowers or improves. How about that? Also, anti-thrombotic events, it decreases that platelet adhesion, increases fibrinolysis, decreases fibrinogen, and decreases the blood viscosity. It is an anti-ischemic property, so it decreases myocardial oxygen demand, increases coronary flow, and decreases that endothelial dysfunction, which we don't like. Also known as ED, but it's not the ED that you men are thinking about. And anti-arrhythmic properties, it increases vagal tone, decreases adrenergic activity, and increases your heart rate variability. All pro anti-atherosclerotic, anti-thrombotic, anti-ischemic, anti-arrhythmic, pathogenesis, which is our goal. So again, here, all adults should accumulate 30 minutes or more of moderate intense physical activity most if not all days of the week. So that's why your healthy people 2020, that's their recommendations. So this is sort of a cute slide that I had encountered on one of our cardiac events, and so I thought I'd throw it in because it's really cute. So an agent with a lipid-lowering, antihypertensive, positive inotropic, negative chronotropic, a vasodilating, diuretic, anorexigenic, weight-reducing, cathartic, hypoglycemic, tranquilizing, hypnotic, and antidepressant qualities. So we need a pill that does all those things. And that was from Dr. Roberts in 1984, so a little bit ahead of his time, I believe. Thank you for listening, and I hope that I provided you with some clarity. If not, watch those videos and email me or call me if you have questions.